All right, let's start by saying thank you to the two members of my audience today, Aaron, charge nurse, Debbie, health service technician, Cedartown Residential Treatment Unit, where they focus on serving individuals who are challenged with mental illness and substance abuse disorders. Get right into it today. Identifying individuals at risk for suicide. The Joint Commission National Patient Safety Goals, effective January 2018. According to the Joint Commission, the organization identifies safety risks inherent in the population of the individuals it serves. Identify individuals at risk for suicide. Rationale. Suicide of an individual served while in a staffed, round-the-clock care setting is a frequently reported type of sentinel event. Identification of individuals at risk for suicide while under the care of or following discharge from a healthcare organization is an important step in protecting these at-risk individuals. Elements of performance. Conduct a risk assessment that identifies specific characteristics of the individual served and environmental features that may increase or decrease the risk for suicide. Address the immediate safety needs and most appropriate setting for treatment of the individual served. When an individual at risk for suicide leaves the care of the organization, provide suicide prevention information, such as a crisis hotline, to the individual and his or her family. Importance and relevance. I know here in Cedartown, from talking with Aaron and Debbie, with the population that they serve, this is a critical part of what they do. I know from talking to them and others that are in this health field, the reason that they work in this capacity is because they care deeply for people. Everyone's life is sacred. Opportunity to encourage, uplift, and instill hope. I think before you talk any more about suicide, identifying people at risk for it, it starts with a culture, it starts with a belief that life really matters. As healthcare professionals, we get to be a part of that process where we're not just clocking in and clocking out, but we're looking at real people in the eye, and we get to believe in them for them when they don't have that belief in themselves. We get to see a better future for them and provide them with hope that they don't have. And it begins there. I think if you're going to identify individuals at risk, you got to see this as less of a job and more of a mission. Research has found that about 90% of individuals who die by suicide experience mental illness. So yeah, population served. That's who you're working with here. Folks that come in that are suffering, that are challenged with a mental illness. Mental illness is treatable. How's that relevant, right? If we are doing the best job we can of working with individuals who are mentally ill and providing them with the treatment that's most optimal, most appropriate, then we're going to see more individuals identified who are at risk for suicide, and ultimately less individuals who complete suicide. Compared to the general population, people treated for alcohol abuse or dependence are about a 10 times greater risk for suicide. Alcohol is present in about 30 to 40% of suicides and suicide attempts. So you see that relevance there as well. Here's a case study. You have a 22-year-old single male, and so as I'm saying this is just a scenario that came to me from looking at the population of individuals that you serve here and that are served frequently in the behavioral health, acute, psychiatric, substance abuse health settings. So as we go over the case study, pay attention for the risk factors that you think are there. Pay attention for the kind of signs that would alarm you to make a different kind of call in terms of their treatment, and how you would properly care for them even as they transition back to the community. In this case study, we have a 22-year-old single male college student athlete. He's brought to the crisis unit from an emergency transportation system. He's coming from the emergency department for a psychiatric evaluation and stabilization. Historically, this young man has done very well academically, but he's been struggling lately. He comes from a high-achieving family. He's at home visiting family. He's at home from college for Christmas break. He's a basketball player. He's in his senior year. He's brought by his older brother to the emergency department after claims of suicidal ideation while he was intoxicated. Said, I just can't take it anymore. There's too much pressure. I don't want to live. History of anxiety since beginning college. No previous suicide ideation or attempts. Alcohol, uses socially. Denies alcohol street use or abuse. Or denies alcohol or street use or alcohol abuse. Family history, he's got his father, suffers from depression. Lives with his parents when he's home from college. Siblings live in the area, they're all professionals. Family nearby. He's had several girlfriends but no long-term relationship. Home for Christmas during school basketball break. He's got a plan to play professional basketball. He's hopeful to be drafted in the upcoming NBA draft. This gentleman was evaluated by the treatment team, determined to not be suffering from a mental illness. He was encouraged to abstain from alcohol and follow up on an outpatient basis with his university's mental health care system. Crisis unit treatment team where he was at corresponded with the University Mental Health Treatment Center. Strongly recommended that the individual be monitored closely and receive professional counseling. Collateral information was provided by the individual's family. Tough case. You're dealing with a human life. You know, when someone starts talking about not wanting to live anymore, you start really taking that seriously. This gentleman had passive thoughts. A passive thought is, I don't want to be here anymore. Life's getting hard. An active suicidal thought is, I don't want to be alive, and I know exactly how I'm going to end my life. You know, I want to shoot myself. So you're looking at the details, but certainly, even for this gentleman as he leaves, you're not going to just discharge him and say, enjoy your life, and and not revisit that, because it's too serious, and mental health is too serious to just go through the motions. So that's why we would recommend him to continue to follow up with an outpatient provider for sessions of counseling, and so that he can continue to follow recommendations from a professional. Inpatient suicide, identifying vulnerability in the hospital setting. As of 2013, of the 35,000 or more suicides per year, about 1,800 are inpatient suicides, meaning they actually occurred in a facility. Over a 10-year period, inpatient suicide is the most common sentinel event reported to the Joint Commission. Why? Lack of a proper suicide risk assessment, not putting the appropriate precautions into place when a suicide risk was identified. Suicide assessment, a couple of sets of mnemonic devices that we can use here to take a look at suicide risk and how to identify the individuals who are at the greatest risk. First one, is path warm. Is path warm stands for ideation, substance abuse, purposefulness, anxiety, trapped, hopelessness, withdrawal, anger, restlessness, mood change. Pay attention to the individual's language. Helplessness, hopelessness, worthlessness, or guilt. These are trigger words. Ask, how hopeless is it? Are you thinking of hurting yourself? Evaluate the frequency and intensity of these thoughts. Ask how in control the individual feels over his or her moods. Mood problem individuals are reportedly those most at risk for completing suicide. Is the patient currently thinking about suicide? Is the nature active or passive? Slaps the next mnemonic device. Specificity of plan. Does the patient have a plan? How specific is the plan? Lethality of the proposed method. Is the method likely to be lethal? Access. Are the means easily accessible? Proximity of helping resources, such as supportive friends or family. suicide risk significantly elevated after psychiatric discharge. I thought this was pretty, pretty interesting, pretty informing for what you do here, because this is where we are. We're in a psychiatric mental health facility, and you're discharging people who are here who have been stabilized. And now what? After discharge from a psychiatric facility, individuals are 100 times the global suicide rate during the 90 days following discharge. These individuals are the ones most likely to complete suicide. Patients admitted with suicidal thoughts, so when they got here, did they have suicidal ideation or gesture behavior? They have had rates almost 200 times the global rates. Analysis suggests that the suicide rate among discharged patients has not decreased in the past 50 years, which means we're up for some change. Like, we're learning more and more about suicide, more and more about how to identify individuals at risk. But the number of folks that are killing themselves within 90 days of leaving a hospital hasn't changed in 50 years. A higher level of clinical monitoring and support is needed to be made available for the first few months after discharge. Ask early, ask often, and ask again. Early. So this is about, when are we asking? Are you having thoughts of wanting to hurt yourself? Tell me about those thoughts. How often and when are we taking a look at someone and saying, is this person at risk? How often are we taking a look at someone and instilling that hope? Early, often, and again. Initial intake admission process. Often, intermittently throughout his or her course of treatment, including at the time of discharge. Again, as we talked about, the individuals most likely to complete suicide are the ones that have been discharged from a psychiatric facility, which I believe says a whole lot more about the suffering that the individual is enduring and a lot less about the fact that they were just hospitalized. But nevertheless, like, that's the target, that's the population. So we ask initially, we ask throughout your stay, and we ask when you return to the community, right? References. I'll close with this, in talking to the treatment team here on that last piece about transition into the community. I think one of the things that's been excellent, that's been put in place, has been the close association between the crisis unit here and the community outpatient treatment team, so that there be intersecting dialogue for the individuals that are at risk, which every individual even here is at risk, so that there's more emphasis on that discharge planning process and that transition to the community. I thought that was really cool. Want to thank you again for joining me in this Identifying Individuals at Risk for Suicide project. I had a good time. Thank you for letting me be here. Bye-bye.